Hi, I'm Bernie Flynn. At New Jersey Manufacturers Insurance Company, we believe that all citizens need to be informed about the important issues that affect their daily lives. That's why we're proud to support programming produced by Caucus Educational Corporation and their partners in public television.
Cardiac care. The future is now. Next on Caucus, New Jersey.
Funding for this edition of Caucus, New Jersey has been provided by Robert Wood Johnson University Hospital, the heart of academic medicine, the Robert Wood Johnson Foundation, Horizon Blue Cross Blue Shield of New Jersey, making healthcare work, TD Bank, Caldwell College, MD Advantage Insurance Company of New Jersey, and by PSC&G, committed to improving New Jersey's economy and strengthening its communities.
Welcome to Caucus, New Jersey. I'm Steve Adubato. You know, there are many minimally invasive techniques for treating cardiovascular conditions, but too often these people are unaware of the treatment options that are out there. Here in the studio to discuss these new procedures are Angelina Correnti, who underwent minimally invasive aortic valve replacement surgery and is doing just great right now, right?
That's right.
Just want to confirm that. Dr. Leonard Lee, Chief of Cardiothoracic Surgery at Robert Wood Johnson Medical School. Dr. Francis Duhay, Vice President, Chief Medical Director, Medical Affairs, Edwards Lifesciences. And finally, Dr. Ken Kutscher, who is Governor, New Jersey Chapter, American College of Cardiology. I want to thank all of you for joining us throughout this program. You're going to see websites where you can get valuable information about this very important topic, cardiac care. The future is now. Question. Doctor, one of the statistics that I said to you before we got on the air, which really blows my mind, and I want to get into that in a second, but aortic stenosis will lead into this statistic. What is aortic stenosis, and why is it that so often it is not being treated?
So aortic stenosis is a problem with the aortic valve, which is the valve at the top of the heart, which over time can get tight or very calcified. And the risk factors of that are the same as risk factors that we see for all heart disease: smoking, high blood pressure, diabetes, renal failure, etc. So when the valve becomes tight, the heart has to work extra hard to push blood through a small valve. The heart gets tired, fluid can back up into the lungs, and you can develop shortness of breath.
Did Angelina have something like that?
She did.
Okay, so she had minimally invasive surgery.
Correct.
This is the statistics that's got me really confused. 80% of all minimally invasive surgeries of this type performed by 20% of the surgeons out there.
That's right. That means that the vast majority of surgery for this type of condition is still done under standard means, which means an incision right down the middle of the chest.
Open heart surgery.
Standard open heart surgery techniques. That's correct.
Okay, so we are not here to advocate one way or the other, but we're here to better understand some of the options for people who have this particular situation. Our understanding is that between 50 and 60% of those who are suffering from aortic stenosis or serious problems like this are not being treated.
That's correct.
And that's not making sense to me. Does that make sense?
Actually, it makes hardly any sense to anyone. And I think as a former heart surgeon myself, I was just flabbergasted by that statistic because in my personal experience, how often do we actually turn down surgery? Not often. But the much broader picture, as you point out, is that a lot of patients aren't even referred to surgeons or cardiologists, mainly because they are either considered too old, their heart is considered too weak, or they have a number of other medical issues that may preclude a safe operation.
Okay, so this is interesting. Certain people are candidates for minimally invasive valve replacement, if you will, right?
Yes.
And certain candidates are not. You were.
Yes, I was.
Because, as you understand it, and you'll correct Angelina if she's not right, why do you think you were a candidate?
I was pretty healthy.
Okay.
Yeah, I was pretty healthy. I'm a strong woman. And I was told that I was a candidate, and I was put into Dr. Lee's hands, and he did it, and I trusted him every which way.
And your aortic valve that was put in came from a pig's heart.
Yes, it did.
Let me ask you, when you were told that, was there any part of you that said, what?
No. No, because I wanted to. I was told that if it was not, it had to be done, okay, by my heart specialist and by Dr. Lee. And if it wasn't done, I could die at any time. I could just die, gone.
Describe what you were feeling before, Angelina, the procedure, and what you felt after.
Okay, shortness of breath. Going up the stairs was difficult. Walking was getting harder and harder because I was getting out of breath walking. Now I'm back on the treadmill 45 minutes a day,
What?
5 days a week at 3 miles an hour.
You're doing that on a regular basis?
5 days a week.
And you attribute that directly to
Yes.
the procedure and what you've done after?
Yes.
Typical? It is fairly typical. She was a good candidate for a minimally invasive approach because she didn't have any other problems within the heart that we had to address, other valves, coronary arteries, etc. It was an isolated valve procedure, so those patients we tend to lean towards a minimally invasive approach.
Doctor, describe your organization and how it's involved in this discussion.
Well, New Jersey College of Cardiology is made up of about 1,500 cardiologists, nurse practitioners, PAs, and surgeons. And we try and educate the public and also work with our physicians to make sure that we have the best care. Right now, actually, interestingly enough, the biggest issue that we have for the state is what to do with angioplasty, or stents. And one of the issues is whether stents can be put in hospitals without open heart surgery backup. And so we actually put on a major symposium about 6 months ago to help the State Department of Health decide whether they should expand putting in stents in local hospitals.
So where does this issue fit in?
About
This whole discussion, yeah.
Well, this issue, we would not be putting in community hospitals in valves. So that would not happen. But I have to, as a cardiologist in a community hospital, have to make appropriate referrals. And obviously I have different choices to make, and I'm going to pick the institutions that take the best care. And we were talking with Dr. Lee earlier, one of the things is that as we get the better surgeons coming from New York and Pennsylvania, we've actually seen that our referral patterns, which used to be to New York and Philadelphia, are now staying within the state.
Let's talk about this whole question of aortic valve replacement, doctor. The minimally invasive aortic valve replacement. If someone were to say, okay, some people are candidates, some people are not. Age is a factor, correct?
Age can be a factor. It's not always a factor in and of itself. We look at the entire patient. We look at their other medical problems. We look at their physical condition. We look at how frail they may or may not be. We look at support structure, family structures, et cetera, to determine whether someone is a candidate for it or not.
By the way, before we go any further, there's some acronyms here I want to clarify, and then I'll come back to this whole question of aortic valve replacement. TAVR, TAVR stands for?
Transcatheter aortic valve replacement.
What is this and why is it important?
So transcatheter aortic valve replacement is an alternate approach. Much like the minimally invasive approach, which goal is to reduce pain and disability, transcatheter avoids the big incision, placing or actually stopping a patient's heart. These valves are inserted either through a cut in the patient's groin or through a small incision on the patient's left chest.
Okay, how often is this being performed?
So recently we received FDA approval. To date, there have been a few hundred, approximately 300 cases of transcatheter valve replacements performed in the United States. However, worldwide, there's been about 50,000 implants that have occurred.
U.S. behind here?
Well, the regulatory approval just came in recently, so yes, it's been delayed by several years before the United States was allowed to implant them.
Let's take the step back. This minimally invasive aortic valve replacement, is it fair to say that, I don't want to say a typical case, because every case is different, right?
Yes.
But in a relatively healthy patient, doctor, is it fair to say that there's a shorter recovery for the patient if they have a minimally invasive aortic valve replacement compared to open heart surgery?
Absolutely. So
why?
So Hospital stay tends to be about a day shorter than standard open heart procedures. Their overall recovery time is about half the time that it would take to recover from a standard incision down the middle of the chest. And a lot of it has to do with the fact that although the risks of surgery are the same as standard open heart surgery, because it's basically the same operation being done through a smaller incision.
How could it be the same operation?
The conduct of the operation is pretty much the same, but we use different techniques to make the incision smaller and work around it. And because it's a smaller, less invasive approach, the recovery times are much quicker.
So why didn't you have the open heart surgery?
I didn't want that.
Why
I didn't
not?
want, I cut down this way? I
Yeah.
don't think so, no.
Okay, say someone said...
I'll tell you, I went to one of my doctors,
Right.
okay, and I told him that I had aortic stenosis, and I need a doctor that would do non-evasive surgery.
Well, why did you say that? Like, why did you say I want it non-evasive?
I didn't want to be cut. I didn't want it. But because I was told the recovery was longer, okay, that the hospital stay was longer, and I didn't want it. I wanted something different, something that was less evasive, and it was done. And I'm happy that I had it done.
Okay, but the valve, my understanding is, and I guess, does it depend upon what material the valve is made of? But in most cases, my research says between 15 and 20 years that a valve lasts.
Somewhere in the 15-year range.
And then what happens?
Well, it depends. It depends on the physical condition of the patient and their heart. So just to differentiate, minimally invasive valve surgery like Ms. Correnti had is different than TAVR. So there are 3 parts to our armamentarium in terms of aortic valve replacement.
Whoa. To your what?
Armamentarium.
That's not a commonly used term on public television, but go ahead.
That's right.
Your armamentarium.
That's right.
The 3 parts of this. Go ahead.
So there's standard surgery, which is the incision down the middle.
Right.
There's a minimally invasive approach, which is what Ms. Correnti had, which is a small incision on the right chest.
Got it.
Then there's TAVR.
There's 3 options out there. You could have said that, but go ahead.
Yeah.
There are 3 options out there.
That's right.
TAVR is the newest and the one that has been performed the least so far in the U.S.
Correct.
Right.
Okay.
And TAVR originally was set up for patients who were felt to be too frail to have one of the 2 valve replacements, either open or minimally invasive. So the initial studies that came out were actually looking at patients who had been refused open heart surgery because they were too old, or the old model.
Frail.
And that was where it was shown to be a benefit, unbelievably benefit. And now the newer studies are coming out to look at patients who are candidates for either traditional open heart or minimally invasive versus the transcatheter approach. And that's where we're going to go in the next 5 years to see whether this approach, whether they're durable, what the side effects are, what the risks of stroke are, because the risk of stroke can be a little bit more, how durable they are.
The risk of stroke is higher with
the transcatheter approach. And so just to...
With the TAVR approach.
With the TAVR approach. And so just to jump on what these gentlemen are saying is that today we try to fit the procedure to the patient. And as alluded to by Dr. Lee, 3 major types of procedures, the full open
Let's go back.
operation.
3 major types of procedures if you have what is called aortic stenosis, which in layperson's language means
a narrowing of the aortic valve.
And if you have a narrowing of the aortic valve, that means what needs to be pumping through that valve, which is
Blood.
You got a problem.
Right.
That's
and we've got to
exactly
open
right.
it up. Go ahead.
That's exactly right, Steve. So one can envision the heart as basically a pump. And there is a valve sitting on top of this pump that can become narrowed, which is the condition of aortic stenosis, such that now the heart has to beat stronger to force an equal amount of blood through that narrowed opening.
Time out. That's not plaque buildup where you go in and the cardiologist says, hey, you've got some plaque buildup and we've got to deal with that. That's different.
Well, as Dr. Lee referred to, and this is absolutely true, it bears remarkable similarities to that hardening of the arteries. It's inflammation, it's fat accumulation, and then finally it's calcification. And so this valve almost literally turns into a rock.
But the treatment is not exactly the same.
Right. One of the problems they found that the traditional medication, cholesterol medication, is not very effective. Aspirin is not very
Cholesterol medication has not, that would not have helped fix Angelina's problem. That would not have fixed her situation.
No.
That's correct. And so the gold standard of treatment today is surgical aortic valve replacement, of which there are a few options.
These are the three we're talking about.
That's correct. And so there is the full sternotomy, which Jean has alluded to. She was not a fan of that, and we hear that often from patients. The other is the minimally invasive approach. As Dr. Lee mentioned, not all surgeons are able to do that approach. And then finally, the newest addition, transcatheter, which is basically plastic tubes that carry the valve through your blood vessels to your heart.
How do we, listen, it's interesting because Angelina went out of her way to research it and figure out what you wanted. And you made the decision in the end with your physician, right? Okay. It's so interesting that 80% of the minimally invasive procedures that are done by 20% of the physicians. But if that is the case, and that number is even remotely correct, then what does that say, doctor, about the level of awareness of consumers, of patients out there, if that is what's going on with physicians? And the obvious follow-up question is, then where are people getting information about these procedures, and then how are they making decisions?
I think a lot of the information comes from their cardiologist, who they have a rapport with, who they've presumably have had a long-standing relationship with. A lot of information is also gained from the internet. You know, people love to surf the internet and ask
you go
questions
on the internet. And you look for what?
Look
aortic blockage?
Aortic valve replacement or aortic stenosis. And you'll see a whole list of things come up related to.
Well, what is the average person going to do with that information? Get confused?
Oftentimes they get confused, but then they go back to their cardiologist and ask them the questions. What do you think? Where should I go? What should I have done?
And is that the best approach?
It often is, because the cardiologist knows the patients well. Again, have a trusting relationship with the patients.
Okay. Angelina, you want to jump back in, I could tell.
But me?
Yes.
No, I just wanted to say that Alan Graham, who is also in the same office with Dr. Lee, did a abdominal aortic aneurysm for me, who stented it.
Right.
Okay, so I go to him every year, and when I said to him I had this problem with the, the aortic valve, I said to him, I need somebody that you trust, because I trusted him. I need somebody that you can trust, that you're going to recommend to me, that would give me minimal invasive surgery. And he recommended Dr. Lee.
So here's what's interesting about this. There are people watching right now who are either experiencing some of what you were experiencing, or they have family members or people they're close to. And they're not sure exactly what to do. So Angelina, here's my question to you. If you were advising those folks watching right now on public television, and they wanted to make the best, most informed decision possible and get the best advice, what would you tell them?
Well, first of all, if you have a, not a surgeon, a heart specialist that you've been seeing for years, okay, and he's the one that's monitoring.
Or she.
Well, he or she, who's monitoring you and then tells you, we ran out of time, okay, you have to go see a surgeon. And I said to him, well, I was given Leonard Lee, Dr. Leonard Lee, by Dr. Graham, and he said to me, good man, go with him. So right away, I called and made an appointment, and we
But that's fine,
went ahead.
but you researched it yourself. You made the decision that you wanted to have minimally invasive surgery. You made the decision that you did not want to have open heart surgery. By the way, if you had come to the conclusion that that was the best option for her, but she kept repeating, well, I don't want that, how do you deal with that?
Well, if that's what I think is the best option for her, then I would certainly argue that point. And if I felt that she was high risk to undergo a minimally invasive procedure, I would certainly let them know and probably not do the procedure.
It's interesting, as technology continues to evolve, the research, the technology, and then the world of the internet is out there. I'm not going to say is it a bad thing, because it is what it is. It's not going to change anytime soon. But people going on the internet to research these things themselves, what are the potential risks associated with that if they're trying to diagnose themselves? Go ahead, doctor.
I think my view is a patient is worried about one patient. That's themselves.
Right.
And I'm worried about 25, 30 patients a day. And so I welcome my patients to bring me information to think about themselves because...
Hey, I read this on the internet, Doc. You don't mind that?
I don't mind at all, and most of them are very open to our interaction. And I'll say, no, thank you for bringing this up. It's a very good point. Or here's what's wrong with what you brought up, but you didn't understand.
Right.
And we have a dialogue. So I welcome people going on the internet. The more informed they are, the better, because as I said, they are spending 24/7 worried about themselves. And I unfortunately can't do that.
Okay. Your thoughts on that?
I would echo Dr. Kutscher's comments. We have an expression we use in medicine called evidence-based medicine, where we like to promulgate our therapies recommendations based on current evidence. Sort of the old paradigm, Steve, is what we called eminence-based medicine, where basically the patient would do whatever the physician asked. So I certainly welcome this new age of patients coming in informed and having specific questions so that the doctor becomes the interpreter and partner in terms of choosing the right procedure for any particular patient.
You know, it's interesting. We keep talking about the term minimally invasive. I don't want to leave any doubts in people's minds or any confusion or any misconceptions as to what that means. What does that mean?
It means exactly as it says, less invasive, but less invasive means a lot of different things
Exactly.
to a lot of different specialties. So as relates to surgery, usually it means a smaller incision. So whether it's done for cosmetic reasons, whether it's done for safety reasons, whether it's done for technical reasons, that's, at the end of the day, it means a smaller incision, and usually means quicker recovery.
Sorry for interrupting. I had minimally invasive surgery because my shoulder, I had to get surgery on my shoulder. I had a torn labrum. Now, if minimally invasive surgery was not available to do that, they would have gone in and reconstructed my shoulder, and I would have had, put it this way, more stitches. They would have gone in deeper, I imagine.
Longer recovery.
Longer recovery, et cetera, et cetera. I know what minimally invasive is because I see what's there, and we talked about it. But that's not a heart.
Mm-hmm. But the same principles apply, whether it's your shoulder, your belly, your heart, your lung, whatever it is. It just means less trauma, hopefully, at the end of the day.
Okay, so in the couple minutes we have left, the most significant and important developments in terms of cardiac care we need to be thinking about and talking about. Go.
Yeah, so transcatheter heart valves is a new technology, as alluded to.
What does transcatheter mean?
Very good question. So basically we take plastic tubes. Physicians call these catheters. The valve is placed over a balloon. The valve is then collapsed over that balloon such that the actual profile of this device is small enough to enter through an incision in the patient's groin and fed up through the blood vessel. She mentioned the abdominal aorta.
That's how that was done.
To her heart at the level of this aortic valve.
Isn't that a stent?
It is a stented valve. And so the stent specifically speaks to a scaffolding or tube of metal. And attached to this scaffold is a valve. In this case, a bovine taken from a cow pericardial valve that is balloon expanded once in the appropriate position. So whereas in the past, patients have had incisions, whether a big incision, a small incision, now no incision in the chest, a small cut in the groin to actually feed this in selected patients. And it's very important to emphasize that today, gold standard is surgical aortic valve replacement. In those patients who are at highest risk or are considered inoperable, a transcatheter solution may be appropriate for them.
Any other, 2 minutes left, any other procedures, any other developments in terms of cardiac care we should be talking about? Go, doctor.
No, I think as Dr. Duhay had mentioned earlier, it's important to make the treatment fit the patient, not to make the patient fit the treatment.
Explain that.
So that, again, we have all these options for treating different disease states.
Hey, I want that one. Right. It's like a menu. You walk in, you go,
exactly.
What do you have? It doesn't work that way.
Not exactly.
It shouldn't work that way.
But that opens us up to be able to treat our patients in the best way we see fit for whatever problem they may have. Instead of saying we have this one option for all comers, now we have these different options to treat you, and hopefully we can make you.
Okay, I got what you're saying. You're saying it shouldn't be just me coming in saying I want option A, but it also shouldn't be you coming in saying all we have is option A.
Correct.
Finally.
One of the things the American College of Cardiology feels about public health, and one of the things we're working on is with the school system to make sure all student athletes are safe with appropriate screening. And the other big issue is having AEDs, or automatic external defibrillators, available at sporting events.
Why is that so huge?
Because not only, the 1 out of 200,000 student athletes years will die suddenly, but also at these events, there are huge numbers of spectators who are cheering. And so any place you have a large congregation of people, we think you should have automatic external defibrillators. We think that the school should actually make it mandatory that the students and teachers all know how to use them.
15 seconds left. You work out every day on your treadmill?
Every day.
How many miles?
I work 2 days a week. I do everything.
And you feel great?
And I'm a trustee. I run where I live. 7 of us run the whole complex.
You're a role model for all of us. Thank you so much.
Thank you.
Great public service. Great job. I want to be like...
The preceding program has been a production of the Caucus Educational Corporation, celebrating 25 years of broadcast excellence. N13 for WNET, NJTV, and WHYY. Funding for this edition of Caucus New Jersey has been provided by Robert Wood Johnson University Hospital, the Robert Wood Johnson Foundation, Horizon Blue Cross Blue Shield of New Jersey, TD Bank, Caldwell College, MD Advantage Insurance Company of New Jersey, and by PSE&G. Promotional support provided by The Star Ledger and NJ.com. Transportation provided by Airbrook Limousine. Caucus New Jersey has been produced in partnership with TriStar Studios.
I've been wrenching for 17 years now. Anything that's got our engine in it, we're working on it. It's nice to know that you have good insurance. Yeah, I'm always comfortable knowing I have Horizon no matter where I go. I don't deal with them a lot, which is a good thing. I have a 17-year-old right down to 17 months. I work hard for my money, and I want to make sure that my family is taken care of, and Horizon takes good care of us.